We notify folks that we're recording this. So if you have any questions or any trouble from an IT perspective during our session today, please send an email to our main Echo inbox there at the OMA that you see on the screen. So next slide. Some helpful tips, just mute your microphones if you're not speaking and just unmute. We've been at this for how many years now as we started a virtual approach to things. So it's always easy to start talking and not have yourself unmuted. We will be watching the chat very carefully. So if any of you have questions along the way for Dr. Mani, our subject matter expert today, certainly she'll take those at the end of her remarks. And then certainly during the patient case presentations, we want those to be very interactive and have your cameras on, and it's really an important part of our echo sessions to really dive into clinical management of patients as part of these. So kind of taking from the lecture component and then more of an integration approach to patient care is really one of the highlights of the echo session. So next slide. Again, the three dots, just choose rename. Sometimes on your screen, we'll have, Janie's iPad or those sorts of things. So if you want to change your name so that we know, who you are, that's also helpful as we refer to you if you may have questions along the way. So next slide. Again, I mentioned this in the chat, which you'll see at the bottom. You can certainly put questions in that you may have during the lecture, and you can reach out to someone individually if you have a private message for them or the whole group. But these echo sessions are great because it really lends itself to a group think in what we do with I'll teach, I'll learn under the echo premise. Next slide. We are careful about PHI information. I'm preaching to the choir when I say things like that because of the work that all of you do, but we are careful to scrub that information out when we receive patient cases, or certainly if you have a patient scenario from your own practice that you'd like to bring forward, we just ask you to be very careful about, reflecting on any PHI that may be utilized in those communications. Next slide. So welcome to each of you, and I'll go ahead to the next slide then, and thrilled to have all of you with us. We always kind of have our ethos of the ECHO program that we highlight as part of what we do, and we use person-first language and items such as the patient with obesity, and we're all centered in the work of the OMA and all of you as an extension of that as our clinicians, as obesity being a chronic and relapsing disease. So we always are centered in that regard. Next slide. So this is our agenda for our time today, and we'll obviously welcome and introductions. We've got a brief didactic presentation that Dr. Mani will be reviewing, and then patient cases, and then we'll wrap things up at the conclusion of our time together. Next slide. With that, I'm going to introduce Dr. Erin Mani, who is an expert in pediatric liver treatment. So this is a really special, really specific topic that is not available to everybody. So we're thrilled to have her with us today. And with that, we'll turn it over to hear her remarks, and she'll be entertaining any questions at the conclusion. Our team will be watching the chat carefully so that we can assist her with those questions, which may emerge during her lecture. With that, I'll turn it over to Dr. Mani, and thank you so much for joining us today.
Awesome. Can everyone hear me okay?
Yes.
Great. Thank you so much to the OMA for having me. My name is Erin Mani. I'm a pediatric gastroenterologist and hepatologist, as well as an obesity medicine physician at Tufts Medical Center, which is affiliated with Boston Children's Hospital here in Boston. And I'll be talking to you today about metabolic-associated steatotic liver disease in kids. I don't think, oh, there we go. Sorry, it's a bit delayed. I do have some research funding from Atai Life Sciences and Trip Therapeutics, but it's unrelated to this presentation and no other disclosures. So our objectives today are to learn how to identify who is at risk in the pediatric population for MASLD, and to apply pediatric specific ALT cutoffs that guide screening and diagnosis. and differentiate really the role of the general pediatrician or general practitioner versus the pediatric gastroenterologist in the initial evaluation and referral of children with persistently elevated liver enzymes. And then briefly, we'll touch on how to implement evidence-based family-centered lifestyle interventions, which are kind of the cornerstone of management for patients with obesity and metabolic-associated steatotic liver disease, and how to recognize when pharmacotherapy or other specialty referral might be helpful. So MASLD matters because it's the most common pediatric liver disease. And in fact, it also accounts for about 5% of all liver transplants and is the fastest growing indication for liver transplant in the young adult. So a lot of the patients who we see today who have the elevated ALT that might get missed for some time or kind of downplayed could go on to have really severe morbidity from this disease. It's strongly linked to obesity and the metabolic syndrome. And importantly, it's often silent until it is late stage. So therefore, early detection is prevention. You might have heard this disorder previously called NAFLD or non-alcoholic fatty liver disease, and now it's MASLD or metabolic associated steatotic liver disease that happened in around 2022. The reasons for that were kind of twofold. I think one, it was felt that MASLD is a less stigmatizing name. So I think having someone say that you have a fatty liver just feels like a little harsh to the ear. And I think for kids especially, and for families, hearing the term alcoholic, even though it's in the context of non-alcoholic, is just like kind of a confusing way to conceptualize the disease. So now MASLD is felt to sort of really more reflect what the disorder actually is, the underlying pathophysiology of it. And it's defined as steatosis in the liver. We'll get into that in a little bit more detail in a second, plus or minus one cardiometabolic risk factor. The pathophysiology is, I would say, still not fully understood, and we know that some patients will develop MASLD at a much like lower BMI than other patients, and that's not completely understood why that's the case. But there's multiple hits, including adiposity and where the fat is stored, with kind of central adiposity and visceral adiposity being more dangerous. Heavily carb-rich or sugar-rich diet, genetic predisposition, some gut dysbiosis as well, which we're sort of just newly understanding, insulin resistance, and a sedentary lifestyle. All of these things combine to create the initial hit of steatosis, and in some susceptible hosts, that goes on to then generate steatohepatitis and potentially fibrosis, cirrhosis, and as I mentioned, it can result in the need for liver transplant in severe cases. It is very prevalent in up to 40% of pediatric patients with obesity, and those at increased risk include Hispanic children, people of lower SES, and those patients with food insecurity. This goes into a little bit more of the natural history of MASLD and how it can over time become MASH. So MASLD, again, metabolic associated steatotic liver disease, and MASH is metabolic associated steatohepatitis. So normal healthy liver here on the left, when you accumulate more than 5% of hepatocytes on a liver biopsy with lipid droplets in them, that would be termed steatosis. Of course, not all patients or most patients get a liver biopsy sort of to have this definition. So we have liver cutoffs that are now known to be associated with that level, but about 5% or more is not physiologic, and that would meet the definition for MASLD. In a small subset of patients, that goes on to become steatohepatitis. So this inflammatory condition with ballooning hepatocytes, fibrosis, and as I mentioned, this is more of the inside, the end stage picture here with cirrhosis. It is also a risk factor for hepatocellular carcinoma. Again, not in pediatrics, but the patients who have this initial steatosis and steatohepatitis and then are living with it for 20, 30 years are at much higher risk of getting HCC at younger ages. So we're really trying to kind of work up front on this prevention in the earlier phases where we tend to see kids. So who to screen? I think that most people on this call are generalists. I'm not sure if that's true or not, but this is more for the generalists who should be getting these screening labs. This is sort of the consensus guidelines from NASPGHAN, who have this publicly available clinical guideline that I definitely recommend if you have interest in the area. And also the AASLD just put out a similar clinical guideline. But in general, children who are ages 9 to 11 and have a BMI for age of greater than 95%, aka overweight or obese, plus or minus one metabolic risk factor. And we'll get into that in a second, but that includes like hyperlipidemia, hypertension, elevated glucose. I think in practice, really just any patient with obesity who are who is 9 years and above, it's reasonable to send a screening ALT, and that's what we recommend sending as the first test to screen for this. So the ALT is much more specific than the AST for liver disease. I think earlier initiation of this screening can be definitely considered. I have patients as young as 5 in my practice who have MASLD. So any patient with more severe obesity or a personal or family history of type 2 diabetes, dyslipidemia, or a family history of MASLD or MASH, it's worthwhile to send an ALT. The primary care role is to, of course, send this screening and then to recognize the elevated ALT. So this is one really important piece that I wanted to highlight is that we need to use pediatric cutoffs and not the adult upper limit of normal to say what is a normal ALT. The upper limit of normal in a lot of adult hospitals, including my own, is I think like 45 or somewhere in there. And if you just rely on the EMR to flag the ALT as red, you'll miss a lot of cases. In reality, anything for boys that's greater than 26 units per liter or girls greater than 22 units per liter. And that difference is because of muscle mass. That can slightly increase the ALT. So boys can be a little bit higher than girls with it being okay. But anything above these pediatric cutoffs is concerning for MASLD, particularly, as I mentioned, if there is also the addition of other cardiometabolic risk factors, including elevated weight, elevated glucose, or like sort of fasting insulin issues, elevated blood pressure, elevated lipids. So after the primary care correctly identifies the patient to screen, identifies the elevated ALT, they should initiate lifestyle management and then repeat to confirm that the ALT remains elevated in 3 months. A transient elevated ALT is actually quite common. There's lots of things that can bump it, including like a viral illness or muscle trauma if they were just very active. So it is important to see that it is a sustained elevated ALT over at least 3 months. Then it's also important to review kind of the history and make sure that other common causes of liver disease are excluded. This includes looking at the medication list and seeing if there's anything on there that can cause liver disease. There's a great resource for this online called Liver Talks. You can also send them to your friendly hepatologist or gastroenterologist if you have access at that point. Less relevant in the peds kind of population, but still important to ask about would be alcohol or drug exposure. And as I mentioned, recent illness, as that can cause like a transient bump in the ALT. It's reasonable to send screening as well for hepatitis B and C if risk factors such as immigration status are applicable, and then starting the lifestyle therapy that I'm sure everyone here is kind of acquainted with. When do you get me involved? So I would say if a patient has the ALT that stays above the cutoff at that 3 month time point, and you have access to PEDS GI or a specialized PEDS obesity program, very reasonable to send at that point. If the ALT is really ever at any point above 80, that would be greater than 2 times the upper limit of normal. And then they really warrant screening for other liver diseases, including autoimmune liver diseases, Wilson's disease, et cetera. And so if it's really ever above 80, I think that could be an immediate trigger to PEDS GI. If there are any signs of advanced liver disease. So these include things like hepatomegaly or splenomegaly, which is sometimes hard to assess on exam depending on body habitus, but if something feels abnormal. If on the liver panel you also see an abnormal bilirubin, any coagulopathy or thrombocytopenia, these could be signs of a more severe liver disease. And any stigmata of chronic liver disease, like spider angiomas, things like that, those are more rare in children. Or just if you are not really sure what's going on after kind of sending a basic workup and it doesn't feel necessarily like something you've seen before, you can send it then. So when they come to us, what our role is to order this broad exclusion panel. And as I mentioned, ruling out some of those other causes that might be to blame for the elevated ALT, including metabolic genetic, infectious, autoimmune, thyroid disease, celiac. Whatever hasn't been done at the PCP, we'll pick it up and go from there. We'll also typically order imaging. At our institution, this is ultrasound with elastography. So it's a specialized ultrasound that can kind of measure the resistance of the liver and give you a sense of both how much fat there is and also how much fibrosis there is. To be honest, it's not super well validated in pediatrics, but it's kind of the best non-invasive thing that we have. There are also modalities that are gaining steam now, like MR PDFF, that can kind of better quantify the fibrosis, but hard to get kids to lay down for an MRI, and not everyone has access to this. So those are the things that we think about. And then in cases where the diagnosis remains unclear or is progressing very quickly, then getting a biopsy is sometimes helpful as well, but not commonly. So that's not something we do all the time. And then our role is also to just stage the disease and kind of manage ongoing, hopefully weight loss, as that is the mainstay of treatment. This is a referral algorithm. It's a little busy, but you think you'll have access to these slides afterwards. This is from an open access paper in Obesity Pillars that I helped write with a few of my colleagues in the OMA earlier this year. So I think it just sort of says a lot of things that I just mentioned to you, but helpful if you want to incorporate this into your own referral patterns. The general management principles are to treat the obesity and treat associated comorbidities. We know that 10% weight loss improves or resolves MASLD in most. This is from adult data, but does seem to be borne out in kids too. So that is a decent amount of weight loss, but it is also doable for families. And I do find having them have like a concrete target that they're aiming towards is very helpful and motivating. Um, I do think on that note also that referral to PGI can be helpful just to kind of like help explain why we're so worried about this, because as I mentioned, it's asymptomatic and sometimes it's hard to get people to be concerned about it. But you can get a lot of buy-in from families when you explain the concerns about liver transplant, about hepatocellular carcinoma, about the long-term risk factors. And I do find that really helps boost motivation. In terms of diet, this could be a whole talk onto itself, but I think the number one bang for your buck is if you can get people to cut out or drastically reduce sugar sweetened beverages. Obviously, these are super caloric and not satiating, and many other things that drive their role in obesity in general. But fructose itself is also very toxic to the liver, especially to an already inflamed liver. So I think that's like the first place that I always start. In terms of the actual diet that the patient wants to do, whatever they can stick to is really the best. But Mediterranean, lower carb options, or intermittent fasting have some good preclinical and clinical data, more in adults than in kids, though. Exercise is important. I typically just start with having people try to walk after meals. That decreases, the sugar in the bloodstream and is protective for the liver. And then in terms of anti-obesity pharmacotherapy, I think GLP-1s are really the mainstay when we can get them to kids based on, FDA approval status and insurance issues. GLP-1s, interestingly, seem to be beneficial to the liver, even aside from their effects on weight loss. They seem to be protecting the liver even outside of that. Metformin and phentermine topiramate do not have that same like hepatoprotective kind of effect to them, but they're sometimes used more off-label for weight loss, or I guess on-label for phentermine topiramate, but more just kind of getting the weight loss, and then that helps the liver rather than helping the liver directly. Vitamin E is a little bit of a wild card. There was a large study in pediatrics that sort of did not quite meet significance, but suggested that it might be beneficial for at least reducing the ALT. But it was a little unclear like whether that actually translates to real world improvements in the biopsy. And in adults, vitamin E over in large cohorts has been linked to increased mortality. So I think the practice is very different at different centers about whether vitamin E is used or not. I think it can be a reasonable thing to try if the patient's very motivated and you're going to do it short term just to try to get the ALT down. In adults, there is also recently, I think as of last year, the year before, resmetirom was approved for MASLD. This is weight neutral, but does seem to improve MASH. Bariatric surgery is something that can definitely be considered, particularly at the more elevated ranges of the BMI. And we do often see really good improvement in the liver disease after bariatric surgery. We do need to monitor these patients long term, and that's an important part of the counseling for patients that they should be getting ALTs every like 3 to 6 months, depending on the trajectory of their weight and the trajectory of the ALT as well. I also think in pediatrics, it's so important to treat the entire family and to just emphasize to everyone that eating this way, moving this way, it's beneficial for everyone's liver. And even if they don't have MASLD themselves, it's much more something that can be implemented and stuck to if the whole family takes this on as a way of eating and living. This is hot off the press. This was from last month that the FDA approved a GLP-1 semaglutide for MASH. And so they got an indication for treating MASH specifically outside of even the weight loss indication, which is huge. This is in adults, not in kids, but it's kind of paves the way for this approval, hopefully to come the way of pediatric MASLD as well. And I really see this as a way of hopefully improving access if an insurer won't cover it for weight, that potentially they will cover it for MASH. In terms of the monitoring, as I mentioned, ALT kind of varies how frequently we get it. I would say for most kids, six to 12 months is fine. I think if it's rising quickly, then we'll do it more frequently than that. An annual screen for type 2 diabetes in the form of a hemoglobin A1C, a lipid panel, and then checking their blood pressure at every visit. And then we really adjust the intensity of the lifestyle and behavioral therapy and the pharmacotherapy based on the progression of the disease. So my take-home points for you are that it's so important to use pediatric ALT cutoffs because using adult cutoffs will miss a lot of disease. That lifestyle is the cornerstone of therapy for everyone. And, we know that the intensive lifestyle and behavioral therapy of 26 contact hours over the course of a year is really ideal. That's not always possible to access. So if you are treating these patients on your own, just do your best. This might mean more frequent visits for weight checks. This might mean having nurses call in to check on them. It might mean giving patients educational materials they can do on their own. Just do your best to approximate, a higher dose of kind of intervention with the lifestyle therapy. Refer patients to your friendly local peds GI if they're high risk or unclear, or again, if they have that ALT greater than 80 at any time. And that primary care is really the front line for prevention, and that hopefully we can catch these issues while they're early and prevent these kids from needing liver transplants or developing HCC. This is that open access paper that I mentioned, so you don't need to have an institutional login or anything to access this. But this is the OMA, and a few of us from NASP again, which is the Peds GI organization, also helped write this. Just some thoughts about how to treat this, thoughts on the different medications, and a lot of the images that I took come from here. So I hope that this is helpful to everyone. And with that, I will leave it there. Yeah.
Okay, thank you so much, Dr. Mani. Some questions in the chat, which is wonderful. The first one is how elevated of a bilirubin would be concerning, if you can comment on that.
Yeah, I think like I would be relatively concerned by like any Billy above the upper limit of normal, whatever that flags for in your institution. A direct bilirubin would be more concerning than an indirect. If it's like an indirect Billy around 2, it's most likely something benign like Gilbert. But if you see any direct Billy bump or any visible jaundice, I think those are both very reasonable times to reach out to Peds GI to kind of get that fuller workup and make sure that MASLD is really what we are dealing with.
Thank you. Next question. I've seen GI physicians prescribe black coffee to pediatric patients. Can you comment on that?
In what context have you seen that? With MASLD?
Lisa, I don't know if you want to come off mute, if you want to expand on that, if you're able.
Yes, hi. Yes,
Sorry.
with MASLD.
I mean, I would say that's not really like guideline based. It's like slightly rogue, but probably not harmful. I'm wondering maybe it has some like stimulant effect that's a little appetite suppressant that could be part of it. So it's like maybe like a poor man's phentermine. The other thought that I have is that black coffee is very high in antioxidants, and we do know that antioxidants can be beneficial in MASLD. So there's some pretty good data about turmeric as well. It needs to be or curcumin, which is the sort of active biologic ingredient in turmeric. The doses that you need for MASLD are like much higher than you would get in like a dish of curry. But there is some interesting, mostly preclinical data about that. So maybe it's a combo of stimulant and antioxidant. I don't know. Probably won't hurt, but probably not as good as Wegovy.
Thanks.
Next question. Given limited access to semaglutide, for example, in children with MASLD, would liraglutide be preferable to phentermine topiramate in your opinion? Jessica says, I don't have a love liraglutide because I simply don't see much weight reduction with it, but I do wonder if it would be more ideal with MASLD.
Such an interesting question. I can look into that more and get back to you specifically, Jessica, but I would postulate that because of like the GLP-1, as I mentioned, being beneficial outside of even weight reduction, that liraglutide probably would be more beneficial than phentermine topiramate. I don't use it much because I just don't really get people bought into doing a daily injection, honestly. It's like just a hard conversation. But I think it probably would be more ideal for MASLD, but I'm not sure off the top of my head.
Thanks so much. I appreciate it.
Yeah. Next question is I think FIB or FLB-4 score helpful in pediatrics at all?
Yeah, so Sleepy is referring to like a clinical scoring kind of algorithm that incorporates in adults. I think it's like platelets and the ALT and a Billy and a couple other things. And it can help guide in adults sort of like what the long-term prognosis is like in terms of need for transplant and things like that is how I think it's mostly used. We don't use it much in pediatrics. I don't think it's been validated in the peds cohort.
Okay, great. Great questions. Let's go to the next slide. What you'll see here is just a highlight of some specific pediatric publications out of Obesity Pillars, our open access journal, as Dr. Mani highlighted. Again, all open access, don't need to be a member, available for download, et cetera. So we've got just a plethora of wonderful pediatric adolescent evidence-based publications in our journal. Next slide. Just some other product recommendations that we have as resources at the OMA and the OMA Academy. The Academy is our learning management system where we house much of the educational CME bearing content, both CME as well as non-CME bearing content. So we've highlighted a couple of pediatric specific elements for your use there as well. So with that, the next slide, we're going to have our patient case presentation by Dr. Reelan. I'm probably butchering your name. I apologize. But you're from Des Moines, Iowa, and I am from Central Iowa too. So that's very fun for me. So anyway, I'll turn it over to you to present your patient case to the group and have input on how to best manage that patient. So I'll go right ahead, and Raina will drive those slides for you as you talk about the patient. So,
can you guys hear me okay?
Yeah, absolutely. Okay. Yeah.
Hi, my name is Shilpi Relin. I'm a pediatric endocrinologist and an obesity medicine physician here at Unity Point Health, Blank Children's Hospital. So I'll talk about a case that I had put this up on the chat a few weeks ago and would love to have others input. Next slide. So this is a 15-year-old white female who basically was referred to our clinic 18 months ago for class 2 obesity. As you can see, BMI here, 133% of 95th percentile. And in addition to that, she had elevated A1C in the pre-diabetes range. She had elevated fasting insulin levels, and the ALT was in 200, so significantly elevated than our pediatric range. She also had irregular periods, acne, and hirsutism. So because of these symptoms, we also did free testosterone levels, and she met the criteria for PCOS. So parents, like guardians, so she's taken care by grandparents, they were very hesitant initially to try any kind of medications. So they just wanted to try lifestyles, and that's what we did. Eventually, the parents were like, okay, the labs were not improving, so they agreed to start metformin. Next slide, please. Okay, so initially we started her on 500 milligram of metformin because that's what the family wanted, and we slowly worked our way up to 2,000 milligram. So she has been on metformin for 8 months now. Her BMI is not much changed, so 129% of 95th percentile. Her vitals, as you can see here, are pretty much in the normal range. The most recent labs, she had a fasting blood glucose of 87. Her A1C is still in the pre-diabetes range. Her liver enzymes haven't changed much. It was in 200s when she presented, and they're still in 200s. I had referred her to our gastroenterologist because of significantly elevated ALT levels when she presented. They did some additional labs, which I'm going to share with you in my next slides, but everything was normal. So all the elevated ALT was attributed to MASLD. She also had, as you can see, elevated triglyceride levels, so very consistent with insulin resistance and metabolic syndrome. Next slide, please. Thank you. So these were the labs that were done by our GI specialists. So alpha-1 antitrypsin was normal. The infection panel was normal. Liver ultrasound showed moderate diffuse hepatic steatosis. And other labs like PT, INR, everything else was in the normal range. Next slide, please. So we have a case, a 15-year-old white female with following diagnosis. So pre-diabetes, class 2 obesity. She has insulin resistance based on her signs and symptoms and elevated free testosterone levels. She has PCOS. Based on her imaging and liver enzymes, she has MASL. She also has depression and glaucoma. Next slide, please. So, because of multiple comorbidities, family eventually they bought into like, okay, we can start anti-obesity medications. So initially, we tried semaglutide, and it was denied. So Iowa Medicaid does not cover any anti-obesity medication. I'm sure you guys are not surprised. So we tried liraglutide, and that was denied as well. And this is something I would just like to know, because I know generic liraglutide is available, but I haven't had any family members who've been able to afford it. So I don't know what other people's experiences are in their states. So usually when insurances, they do not approve anti-obesity medication, I resort to like off-label topiramate or phentermine. Because of the history of glaucoma, I felt topiramate might be a better option, but it's still like we have to exercise caution when someone has glaucoma. So I reached out to our ophthalmologist here, and they said because her angles were open, it's okay to start topiramate. So I started her on topiramate. So usually I do 25 milligram, go up every week by 25 milligram to a maximum of 75 milligrams. So I haven't seen her after starting topiramate. I'm going to see her in the next few weeks. So we have a case here. She's on topiramate. She has multiple comorbidities. We continue to give metformin. The GI specialist was fine with that. She continues to be on Sprintec because of irregular cycles. So any, next slide, please. I think that's all I have. So yeah, any suggestions on like how to, take care of this case, or anything else, if anybody can contribute, I think that would be awesome.
You can go to the next slide, Raina, if you wouldn't. A couple items in the chat. Any luck with Trulicity based on the pre-diabetes is a question.
No. So yeah, we always try to do that. But I have never had any luck because they're very strict about, she does not have diabetes, or any patient. I have tried like pre-diabetes for a lot of like other obesity medications and other GLP-1s, but I haven't had any luck yet.
Another question, how do you prescribe the medication doses off label?
So I usually talk to my families, like this is an off-label use, but there have been trials. So for topiramate, I usually tell them there have been some randomized control trials in topiramate, but then I also talk about this is a medication, the combination, the phentermine and topiramate, there's research and it's FDA approved. These are basically the same medications, but giving them off-label, they're a lot more reasonable. So I talk to them that it's off-label, but there've been studies, and then I document that. And I prescribe it. And usually I've been pretty lucky getting it approved by insurance, because both phentermine and topiramate are pretty cheap. So I have not, even under the diagnosis of obesity, I've seen insurances like approve it.
Jessica, do you want to come off mute and just kind of describe your letter of medical necessity and kind of the appeal that you're providing some information on?
I feel like in Georgia, we're always banging our heads against the wall. But it's interesting. I've kind of over time, sort of multiple iterations of started citing the EPSDT clause, and this is a federal mandate that states who are implementing Medicaid, so all the different payers, so in Georgia, thinking about Peach State and CareSource and Amerigroup, they're called upon by this federal mandate to essentially allow, and T stands for early periodic screening, diagnosis, and treatment. But it's essentially a mandate that states are required to fill anything a provider deems medically necessary. It's interesting. I had heard kind of murmurings about this But it seemed like nobody knew what it was. And I'm just I'm excited that Valerie mentioned it because it's something that I just recently started adding it to my appeal letters. So kind of TBD on whether or not it's going to be working. I've tried different tactics in terms of citing cardiovascular risk specifically and talking about the SELECT trial and looking at improvements in cardiovascular risk factors to try to, angle things away. And it seems like each little thing helps, but I'm really hoping that this EPSDT clause can get some denials overturned. I'd love to hear from Valerie too. Yeah.
No, that's exciting. I think for us in Maine, we started talking about this, my gosh, probably in 2018 when Nancy and I were running our multidisciplinary clinic just to get coverage for access to care, regardless of medications. And it tends to be underutilized. So at one of our pediatric board meetings, a lawyer from our state Medicaid came and said, we have these funds. And I'm like, can I use it for medication? She's like, absolutely. So it is labor intensive, I'm not going to lie. But you do take that denial that you're getting, right? And then you use that to submit sort of a special prior authorization called the EP. And you typically have to do exactly as Jessica's saying, say why it's medically necessary. They typically will ask for an office note, laboratories, things like that. And then for us in Maine, it might be variable across different states, but it tends to go directly to our medical director who makes a case-by-case determination. And then if it is approved, the state pharmacist will communicate with our local pharmacist to get coverage. It does require kind of watching because every time you want to titrate that dose, you have to sort of ask again. So it does require a lot of back and forth. But once they get to maintenance and you can do a longer prescription, it has made the difference of no med versus med. Is it perfect? No. But until TROA and all the other things that we try to do to universally have access, it has been a game changer for a lot of our kids in Maine.
I just have a very quick follow-up question, maybe on behalf of myself and the group, Valerie, but who handles your prior authorization?
Yeah, so I just recently changed positions, but at my prior hospital-based, it was really our nurses who are in the staff. We just recently had added a pharmacist who is likely going to help us with that. But it was myself and one nurse particularly that we were like back and forthing and had like an Excel sheet to say, do we send a reminder? So it is not easy, but it can be streamlined. So where I am now, I've just recently joined Knownwell. We have a whole pharmacy team and a prior authorization team, which can streamline that. So it is not straightforward, but it can work. So and the other part too is the more we ask for it, if we're never asking for these prescriptions, then they're not seeing a need. And they're just saying, whatever, complacency. So as much as it is a real challenge in terms of labor and workforce and time and commitment, I think all of those things continue to push the envelope in the right direction for our kids.
Another comment, are you tracking lifestyle change with the patient? And do we know if there's implementation of lifestyle changes or dietary changes that the family can help the child with? So, shopping, cooking, those, just some kind of expansion on that with this patient.
So yes and no. Yes, because we know like this family is trying their best, but also like this is a kid who has a lot of social barriers. Like the parents are not in the picture. There's a history of depression. So yes, and grandparents are pretty like good about like cooking at home. So they are doing what they can do in their capacity. And that's why I believe the BMI has kind of stabilized. But yeah, this is a kid that is just that we have not been able to get anywhere with the medications. And I think the other barrier was also like the family was initially, so I think this is one of the families who just don't trust medications, and that's how they came when they came to me initially. But now I think they know, like when we've talked about the complications and the risk, weighing the risk and the benefits of treating versus not, they are. But I believe, like, based on what they've told me, they're meeting with that dietitian, like they are doing whatever they can do in their capacity.
So clarification, I think folks are seeing in the chat, is EPSDT just for Medicaid? And the answer is yes, Jessica says, for that specific patient population. And Dr. Francavilla, do you want to comment on virtual help with PAs since you've got experience in that space for the group?
Yeah, I was just commenting, when you suggested, Valerie, like potentially hiring a pharmacist for this, that pharmacists are obviously very highly skilled, and we value them on a clinical team. And I think that would be a very expensive role for someone to be working on prior authorizations for most clinics. So some people are using AI and other things, but we use virtual assistants in our clinic, which has worked very well and is very cost effective for us to be able to get those prior authorizations processed timely and quickly for patients.
Love that idea for sure. I'm going to pick your brain, Carolyn, later on all of those things. I think for us, we because we're part of a bariatric surgical team, the pharmacist was already sort of embedded. But the pathways, once you have the pathways set, I think that could work super well and streamline things for people day to day for sure. Love that.
Just some comments there, Dr. Rowland, for you to look at there. What about the activity after school programs? And Dr. Harris says it expires at age 21 for patients. And then the question about support for insulin resistant of PCOS. Do you see that question there in the chat?
Yeah.
If you
So
can just address that. So
I haven't used that medication. I'll have to look more into it. Yeah, I haven't used that medication for PCOS, but that is something I can definitely look into. I just don't have any experience. But yeah, I'm happy to learn. And the after school programs, we haven't a lot of, I mean, I can look into it. I just feel that some of my patients, they live in areas and the school programs are not great. But definitely I can look into it. I was just not aware that that is something I could. Yeah, I think that's helpful. Thank you for the medical necessary. Yeah, but yeah, that medication I can. Then the next question is, if she's not an antidepressive, you could consider bupropion. Okay, Vyvanse. Okay, with diagnosis of impulsive. Definitely
and
look
then
into it.
comment on samples for GLPs, if anybody can comment on that, if those are available for your patients.
So we do have samples, I believe, but I think the issue is like those samples. I think I'll have to talk to our rep, but I believe those samples are for insurances that approve, and I feel that those samples are not gonna last. So I mean, I just don't have, because if you give a sample for a month and then the patient responds and then you stop the medication, you go back to where you were. So I just don't like, it's not like growth hormone that you've done like a financial letter and then they are on it for like several months. So I just don't have any experience with that, but I can definitely look into it.
And I think earlier, Jessica, there was a request, if you wouldn't mind sharing your letter, obviously de-identified. If you want to send that in to us, we can get it to this group to utilize if that's something you're willing to share. So yeah. Happy to distribute that. So, and then just some comments about how folks are getting samples at starter doses and those sorts of things. So, just a comment around Vyvanse there has been successful in children with appetite suppression. Any other comments anybody wants to make about Vyvanse or utilization of that with this type of a patient?
So just a question. I don't know if somebody has experience with this. So I know phentermine is contraindicated in glaucoma. I believe Vyvanse is fine, right, with respect to glaucoma. I just haven't had experience with glaucoma and Vyvanse.
Any other comments on the medication in the chat that's being mentioned here? Berberine, I'm probably butchering the name of that, but
I think I've heard of berberine referred to as nature's metformin. I don't have any patients on it, but I have heard of it just kind of colloquially. I don't know much about it, but I know that it's not regulated since it's a supplement. But, Carolyn says berbeриne's better than nothing, but metformin works better.
Mm-hmm. Well, great. Great discussion. I think if nothing, we've got this nugget of an amazing letter of medical necessity from Jessica's team that we can share for the betterment of the good. So it's great. So let's go on to the next slide. We've got just a few minutes here to talk about another patient case that was submitted. And Dr. Brown, are you going to be reviewing this patient with the group?
Yes.
Yeah, go right ahead.
So this was submitted by Dr. Hurdes at Stanford. She's unable to be here now, but this will bring up some more questions. This is an 8-year-old male, and the age at onset of his obesity was 5 years old. He's hungry constantly, but he does not qualify for binge eating. He does no night eating. He does no stealing or hiding. Dr. Hurdes has tried to reduce sugar-sweetened beverages and has tried walking. His associated conditions are OSA, sleep apnea, and he's had his tonsillectomy, adenoidectomy, and he also qualifies for MASLD. He's not on any medications. Next slide, please. There we go. There's a family history with mother having obesity. The mother's not had any anti-obesity medications or metabolic and bariatric surgery. A complex social situation, lives with mother on weekends and with grandmother during the week. The boy himself is concerned because he cannot run fast. He's doing okay in 2nd grade, but he is bullied. And he's worried about getting picked on at school and has a degree of food insecurity. His blood pressure is normal, but he's got class 3 obesity, 141% of the 95th percentile. On exam, he has acanthosis, nigricans, otherwise normal. And his labs show an ALT of 54. That's a good one for Aaron. Lipids are normal, and he hasn't had any imaging. Next slide, please. So I think what I'd like to hear are some recommendations about where to go with this young man.
If you would like me to go back to the last slide so that you can see the information, just let me know.
Yep, go back.
Question on what the A1C was.
It wasn't included in the presentation, so I can't tell you. How would people start with this child? Would you bring up the topic of anti-obesity medications and metabolic and bariatric surgery, or would you try lifestyle for a while?
In the chat, Dr. Brown, referral to an RD, getting a fasting insulin, and obviously A1C. Obviously, we didn't. That might have been collected, but we don't see it here. So
here we go. Here comes some more suggestions. Great.
Yeah. Is there a leptin deficiency? Screen for ADHD. Looking at genetics, genetic testing.
When people say genetic testing, are most people just sending like the Overcoming Rare Obesity genetic panel, or is there something else that in most people's practice?
I guess we'll go back to the chat again.
Mm-hmm.
Teresa? Yep.
Yeah. Let's see here. Consideration, Jessica saying topiramate and Vyvanse for this patient. Yeah, agree with Vyvanse and topiramate for this patient. Dr. O'Hara is wondering, and we may not know, was the obesity onset before age 5 with hyperplasia?
No, it was stated as age 5.
Okay. Looks like folks are using the prevention genetics as the go-to for genetic testing in such a patient. So. Any other comments anybody has about managing this patient? Your thoughts? Diet and activity tracking, what's the socioeconomic situation? I think probably what we have is what you see there, kind of on the patient's living situation. A recommendation for a fibro scan to assess for liver fibrosis. Some dietary recommendations as well, and educating the family. Repeating the ALT in 3 months.
Yes, I think this boy needs to be followed closely, and I think with his early onset and rather severe class 3 obesity, one has to open up the book on him to help prevent him from suffering consequences of his obesity. And I was happy that this was brought up because, of course, the AAP, in spite of the implications in the most recent recommendations in 2014, they explain off-label usage of medications. It's a very useful paper when you're worried about it, because it points out that we pediatric providers do a lot of off-label work, as a matter of fact, and we have to be aware of that and not put the disease of obesity in a different category. But of course, the other problem with the anti-obesity medications is getting financial support for it. But this boy is in a bit of a pickle with the severity of his obesity, his presumed at least pre-diabetes, and his MASLD.
Just a comment around addressing the bullying, which will perpetuate a disordered eating as well. So addressing that. And then Dr. O'Hara says the clinical practice guideline does say to consider AOMs for 8 to 11 years of age when significant disease and complications, kind of as you're alluding to, Dr. Brown. And then a question about whether the child's on CPAP. If not, maybe assessing that for regulation of sleep.
And I think it's, as is being pointed out in the discussion, this boy needs a multidisciplinary effort, including diet, including activity, including his mental health support.
Lisa says if he's in California, I've heard other obesity providers get coverage for GLP-1s off-label through Medicaid.
So I think what we can do, Teresa, is make sure we copy down all these chat suggestions and send those along to Dr. Hardy.
Yep, absolutely. Great comments, everyone. Thank you. Okay, go ahead to the next slide in the interest of time. We do offer CME for echo sessions. And so you see there on the screen within 2 business days, you'll see that added to your OMA account. Contact us through our echo email if you have any questions or any follow-up that we need to help support you with. And then on the next slide, just highlighting our next echo session, which is on Friday, October 3rd. And then one of the things that we do in wrap up from the cases that we present is just provide, as Dr. Brown is indicating, kind of some elements of follow-up for the clinicians that submitted the case. I think probably our best nugget today is the letter of medical necessity that we'll be getting out to all of you from Jessica. So thank you so much for being willing to share that. Many pain points for all of you clinically in the field trying to get these medications covered and access for the patients that you're serving. So anyway, we also just encourage, you see in the chat there, submitting cases for upcoming echo sessions. It doesn't need to be a pediatric case, but it certainly could be a pediatric case. We love hearing patient cases because that's kind of, I think, around the ethos of echo, all teach, all learn. So great discussion today, great suggestions, wonderful attendance, and Katie just put in the chat there to the post-session feedback, and we'll link to this recording in the system as well. So if you want to re-listen to this discussion, and the slides will be available too. I think that was an earlier question that we had come up, so we'll have that available for participants as well. And again, appreciate everyone's attendance, and we'll go ahead and wrap up from there. And
I'd like to just thank
go
Dr.
ahead.
Mounty.
Sure.
I'd like to thank Dr. Mounty for an outstanding presentation.
Yeah, really great.
Thank
The
you.
liver
Thanks for
problems,
having me.
the liver problems are a little bit the elephant in the living room because they are hard to diagnose, and so it doesn't stick out. But they are there, and those of us who've worked with studies looking comprehensively at kids with a disease of obesity believe that 40% number. So we have to raise our level of suspicion as we are helping these kids and families.
Yeah,
Absolutely.
great. Yes.
Thank you, guys.
Yeah, thanks everybody for your participation, and have a wonderful weekend. We appreciate